Our second speaker is Professor Mark Strachan. Mark is a consultant physician in endocrinology, diabetes, and acute medicine at the Western General Hospital, Edinburgh, and he is an honorary professor at the University of Edinburgh. He's also secretary of this college. Mark did his medical training at the University of Edinburgh. He is one of the principal investigators of the Edinburgh Type 2 diabetes study. He's published over 100 original articles and book chapters, and he was recently appointed as editor of the major international textbook, Davidson's Principles of Practice of Medicine. And actually yesterday, Elsevier visited us and gave us 19 editions of Davidson's Principles in Practice of Medicine. Mark.
Thank you very much. Good evening, everyone. It's a real pleasure to be here today. So my lecture, I'm a medic rather than a historian, so naturally I'm going to concentrate more on the clinical aspects of diabetes. But what I want to do is to give you a flavour of how the treatments of diabetes have changed over the years, and highlight why that is now particularly relevant for us today in trying to ensure that we get the correct diagnosis in people with diabetes. So diabetes, or diabetes mellitus, to give it its proper title, is very, very easy to diagnose. All you need to do is to take a blood sample from someone and show that their sugar level is elevated, and you've made the diagnosis. If I'd been standing here 200 years ago, the diagnostic procedure was slightly different in that instead of taking a blood sample, you would have got a sample of urine from the patient. And the doctor would have tasted the urine to see if the urine was sweet. Thank goodness things have moved on in the last 200 years. I'm not quite sure I could quite handle doing that. So making a diagnosis of diabetes mellitus is very, very easy. But the differential diagnosis in terms of the underlying causes of diabetes mellitus is very broad indeed. And that's where the diagnostic difficulty can occur. So in numerical terms, by far and away the most common form of diabetes is type 2 diabetes. Then you get type 1 diabetes, which makes up around about 10% of all cases in the United Kingdom. And then you get some real rarities, which we lump together as the so-called monogenic, or genetic forms of diabetes. Now, type 1 diabetes is what we call an autoimmune condition. So basically, in type 1 diabetes, your body attacks itself. And in the case of type 1 diabetes, it's attacking, it's attacking these cells here, which are called the islets. So this is a slide taken from the pancreas gland. Now, the pancreas gland is a funny gland in that it makes all the digestive enzymes that we use to break down food after we've eaten it. And those are secreted directly into the bowel. But the pancreas gland also makes hormones that go into the bloodstream, and predominantly amongst these is insulin. And what happens in type 1 diabetes is that you get an attack on the islets in cells of the immune system that effectively destroy the insulin-producing cells. And so what that means is that people with type 1 diabetes have an absolute deficiency of insulin. Or rather, that's the standard textbook teaching. And so people with type 1 diabetes need treatment with insulin, and that is a lifelong treatment. Now, we can measure in people with type 1 diabetes markers of this autoimmune process, this process of destruction of the pancreas by the immune system. And we can measure antibodies in the blood. Type 1 diabetes classically presents in people of young age, so people in childhood, in early adulthood. So if this young chap came along and saw me and had a high blood sugar level, it would be virtually, but not absolutely certain, that he had type 1 diabetes. Martin mentioned that, in the past, the presence or absence of ketones was used by clinicians to work out what type of diabetes somebody has. And in fact, we still do that today. So if somebody has got ketones in their blood or urine, that absolutely pushes you down a diagnostic path for type 1 diabetes. Ketones are important because they are an alternative energy source for our cells. So people with type 1 diabetes, the sugar is in their blood, but it can't get into the cells. And so the cells are starved of energy. And so ketones are made as an alternative source of energy. Type 2 diabetes, as I said, is by far and away the commonest form of diabetes. Type 2 diabetes is predominantly a genetic condition. So 65% of all susceptibility that we have to developing type 2 diabetes is inherited from our parents. But it's not one single gene, it's not one single genetic abnormality that confers susceptibility to type 2 diabetes. There are probably over 200 genes that confer susceptibility to type 2 diabetes. And we all have these genes, but we just have little variations in the genes that make us just a little bit more or a little bit less susceptible to get type 2 diabetes. Type 2 diabetes is not associated with a lack of insulin. People with type 2 diabetes generally make lots of insulin. It's just that the insulin does not work properly. They have what is called insulin resistance. So the insulin, when it binds to the cells, just doesn't elicit an effect. There are very strong associations with type 2 diabetes with increasing age. So classically, people with type 2 diabetes present in middle age and older years, and there is a strong association with body weight. So people who lay down fat, particularly around their tummy, are more susceptible to get type 2 diabetes. And there's a strong racial element to type 2 diabetes. So people of South Asian or Afro-Caribbean heritage are at much higher risk of getting type 2 diabetes. People with type 2 diabetes classically make no ketones and make no antibodies against the pancreas. And the monogenic forms of diabetes are rare. They make up about 1 to 2% of all diabetes. And these are single gene abnormalities. So you inherit one faulty gene from one of your parents, and that makes you liable to get diabetes. And this was the family from Nottinghamshire where monogenic diabetes was first identified in the 1970s. And the figures over each member in the wedding photo is the age at which they developed diabetes. Now, there are many different forms of monogenic diabetes that affect many different genes. And depending on which gene you've inherited, it may be possible for you to be treated with tablet forms of treatment. Now, Martin mentioned Martin's very first slide was the slide showing the average life expectancy of diabetes in the first half of the last century. And if we'd all been here 100 years ago, so in 1919, I would have said to you that either of those children who were in the slides there had an average life expectancy of about 2 years. These were children who had been diagnosed with diabetes. And at that stage, diabetes, what we now know as type 1 diabetes, was a terminal illness. It had a life expectancy much shorter than most cancers that we see today. So type 1 diabetes was a lethal condition. And then these guys came along. This is Frederick Banting on your right and Charles Best on your left. And I would love to tell you the story of what these guys got up to in Toronto in Canada in 1921 is worth about 3 lectures in its own right. And I would love to tell you the story, but I don't have time to tell you the story. But it is an amazing story that shows you the best and absolutely the worst of human personality and endeavors. But these guys were the ones who discovered insulin, or rather, they managed to isolate insulin, initially from the pancreas glands of dogs, and then latterly from the pancreas glands of cows, pancreas glands that they got from the local abattoir in Toronto. But these guys were amazing, and they discovered insulin, and insulin in the aftermath became available for the treatment of type 1 diabetes. And although, as Martin said, it was thought that this would completely transform the life of people with diabetes, it wasn't by any means perfect. And life expectancy for people with type 1 diabetes in the first half of the 20th century was still very, very short indeed, because the insulin treatment was imperfect. But there's no doubt that over the intervening 100 years, the quality of the insulin that we have available has improved immeasurably, but it remains imperfect. There is no way that injections of insulin can mimic the finely tuned system in our pancreas glands that exists in people who do not have diabetes. So insulin is amazing, but it's not perfect. Now, Martin said I would show you some instruments of torture, and these are some of the devices that were used in the management of type 1 diabetes last century. That's a glass syringe. This is a device that allowed for people who were struggling to inject themselves. This effectively device fired the insulin syringe, bang, right into the top of your leg or the top of your arm. So there's no doubt that the way we have to deliver insulin has improved immeasurably over the last 100 years. This is the very first insulin pen made by a company called Novo Nordisk, who are based in Denmark. But actually, the original idea for the insulin pen was a Scottish idea. It came from two Scottish clinicians, Ireland working in Glasgow, and Sheila Reith, who spent most of her career in Stirling. And they came up with the idea of the insulin pen. And again, over the last 20 or 30 years, insulin pen technology has improved enormously. The gold standard, though, for giving insulin these days, though, is by a pump device. This is the very first insulin pump, which it almost looks as though it's one of these rocket pack things, for flying up into the sky. So this was invented by a very astute clinician working in London called John Pickup in the early 1970s. And you can see that it was not the most practical of insulin delivery devices. So this is the current insulin pumps, or one of the current insulin pumps that we have. So insulin is loaded into a syringe in the device, and it gives the insulin via a giving set into the tissues just under the skin, usually of the abdomen. And this is a very, very good way of delivering insulin to people with type 1 diabetes, but it's not perfect, far from perfect. This is one of the very first blood glucose monitors. So one of the mainstays of monitoring diabetes is the finger prick testing of blood. And that came in the 1970s. This, I have to say, really looks like an instrument of torture, but it was actually one of the early finger pricking devices. So you would put your finger underneath the little yellow piece of plastic there, press the red button at the top, and the guillotine would come down, bang, and would prick your finger. I can't imagine genuinely the courage that it must have taken to have your finger under that, waiting for that device to come down and prick your finger. But finger pricking, intermittent blood testing of blood sugar levels, is not perfect. And it's not perfect because people with type 1 diabetes have got enormous variability in their blood sugar levels on a day-to-day basis. So the graph here, the heavy line is the average blood sugar level for this one individual. It's not bad. It's pretty good average overall. But each of the individual graphs that you see, and there's about 20 of them overlaid here, are individual 24-hour tracings from that same person. And you can see that sometimes her blood sugar level is up here, and sometimes it's down there, and it's just swinging like a yo-yo up and down. And you can see the problem with finger prick testing. Even if you're testing finger pricking 4, 5, 6 times a day, just depending on when you do the test, it might be here, but then 10 minutes later, it might be up here, and you don't know that because just of the nature of the timing of your blood test. So finger pricking is not perfect. This is getting pretty good, though. So this device here is called a Freestyle Libre device, and it's worn usually in the skin of the upper arm. And this is a continuous glucose monitor. So this monitors blood sugar levels constantly over a 24-hour period, and can be worn for 2 weeks at a time. This is an amazing device. It costs about £65 for the 2 weeks. Believe you me, it's worth every penny of that and more, because it gives the person with diabetes so much more information about what their sugar levels are doing. This graph here is stolen from my friend and colleague Fraser Gibb, who's a consultant at the Royal Infirmary. And Fraser audited the impact of introducing the Freestyle Libre at the Royal Infirmary Diabetes Clinic. The Freestyle Libre device became available on prescription last year in Lothian, and so we were able to start giving it to people with type 1 diabetes on prescription. And you don't need to worry so much about the numbers inside here, but basically the green bars are people before they got the Libre, and the cluster on the left are people before they got the Libre, and this is people after they got the Libre. The green bars are people with good control, average control, and not good control. So you can see that after the Libre was introduced, the proportion of people with suboptimal sugar control fell from 20% to just under 10%. And that's with a monitoring device. That's an amazing, amazing improvement. I think this is one of the biggest improvements in diabetes care in the whole of the last 50 years. It's an amazing device. There are other forms of continuous glucose monitoring now, and what the holy grail now is getting the continuous monitors to talk to the insulin pumps and switch the pump off if your sugars are going low, and switch the pump back on as your sugars are going high again. And that technology now exists. So this is the current system that's available, called the 670G hybrid closed loop system. And this device, if somebody with type 1 diabetes wears this, it can absolutely transform their sugar control. The problem with this, though, of course, is the cost. This is very expensive technology. Now, I'm obviously hugely biased, and I think, again, this is worth every single penny. The transformative effect this can have for the person living with type 1 diabetes is immeasurable, and the impact for that person as well in reducing the risk of complications of diabetes is enormous. And that then, of course, feeds through to benefits to us all in terms of reduced healthcare costs of diabetes. But this is a challenge for governments, not just in Scotland, but across the whole of the world, in being able to provide this technology. And of course, I'm talking here about resource-rich countries. There's absolutely no chance in the world that this technology could be afforded in resource-poor countries. It's impossible. And of course, that's one of the great world inequalities that we have in healthcare. But this This is absolutely the future of type 1 diabetes in my book. This, I think, will transform everything. So this is what's called the bionic pancreas, or the dual hormone pump. So this pump has actually got two syringes in it. One syringe has got insulin in it, like a standard insulin pump, but the other syringe has got another hormone in it called glucagon. Now, glucagon is the mirror image of insulin, and it does the opposite. So glucagon raises your blood sugars, whereas insulin lowers your blood sugar levels. So what this pump does is incredible. It's a bit like driving a car with one foot on the brake and one foot on the accelerator. So with this pump, as your sugar levels are going high, it just gives you a bit more insulin. And if your sugar levels are going low, it drops down your insulin and gives you a bit more glucagon. The best thing about this pump is that the human element is taken out of it entirely. So with this pump, you literally put it on and you forget about it. There's no carbohydrate counting, there's no working out how much insulin that you have to have. It's astonishing, but it's not available yet. They're still testing it. But it will come. I have no doubt at all about this. This will come. This will be a major, major, major advance. But guess what? It's going to be really expensive. And that will be the problem with this. We can also transplant islet cells. So the cells that make insulin can be transplanted into someone with diabetes. They're taken from the pancreas gland of a deceased person, so it's a form of organ transplantation. And this is performed in Edinburgh. Edinburgh is the Scottish National Centre for Islet Transplantation. And for a tiny, tiny minority of people with type 1 diabetes, this can be a life-transforming treatment. But it's not for everyone. You have to take very powerful immune-suppressing drugs. And it's not a treatment for the future, I don't think. There may be an option of having stem cells that you then don't have to take the immune suppressants. But the problem with this is you're injecting the cells into the liver, and you're just injecting the cells in the wrong place. And so I don't see this as being a real player in the future. It's going to be technologies. Now, what about type 2 diabetes? So type 2 diabetes, again, the therapeutics of type 2 diabetes have moved forward massively over the last 10 years even. Type 2 diabetes, it's a total joy now to be seeing people with type 2 diabetes. And I don't mean that in a negative way. What I mean by that is that we've got so much more to offer now in terms of treatment than we did in the past. But actually, the most important aspect of the management of type 2 diabetes remains diet. So type 2, most people, the overwhelming majority of people with type 2 diabetes will have a degree of central adiposity, weight around the middle of their tummy. And if you can lose that weight, you can actually put your type 2 diabetes into remission. That's been shown on TV programs like the Fast Fix, but it's been shown in big research studies, one just published a few weeks ago. So you can put type 2 diabetes into remission if you can lose enough weight. The problem is that, of course, it's very difficult for any of us to lose weight. We all find, we all progressively put more weight on as we get older. That's just what happens as we get older. And we all find it very, very difficult to lose weight. So to say to somebody with type 2 diabetes, okay, we need to get you to lose 15 kilograms in weight, is a really, really, really big ask for someone. But if you can do it, it can be, again, transformative. We've also got really, really good new treatments, though. There's one class of drugs that makes you pee out called the SGLT2 inhibitors. Don't worry about all the stuff in these slides. I just needed something to put on a slide to allow me to talk about it. But SGLT2 inhibitors are amazing because they make you pee out sugar in your urine. So the same thing that happens in people at the time of diagnosis, we're actually now inducing therapeutically. This is really good because if you lose the sugar in your urine, you lose it then from your blood, so it lowers your blood sugar levels. By losing sugar in your urine, you also lose calories. You lose about 300 to 400 calories a day in your urine by taking these drugs. So it helps people lose weight. So it, again, affects the underlying cause of the diabetes as well. The GLP-1 agonist treatments, these are injection treatments, usually given once a week now. And they, again, help people lose weight. They have an effect on the appetite centers of our brain. They make you feel a bit fuller so you don't eat so much. And they also give you a turbo boost on your pancreas to make you produce more insulin. So these drugs are amazing, and there are more and more of these drugs coming on site. We can also do surgery for type 2 diabetes, so-called bariatric surgery. Most bariatric surgery involves procedures where you cut out part of the stomach, so you feel fuller after you've had a meal. These treatments are astonishingly effective. People can lose 20, 30 kilograms in weight with these treatments. But it's a big operation. It's a big operation for somebody with diabetes, for somebody who may be overweight, to go through that operation. So again, this is only ever going to be a treatment for a tiny, tiny proportion of people. The more effective options in the future for type 2 diabetes will come through drugs rather than surgery, I would predict. Now, this is Sophie. Sophie's a nurse. Sophie was diagnosed with type 1 diabetes when she was 7 years old. I think it would be fair to say, Sophie would be the first to say that when she was diagnosed with diabetes, she found it very difficult to manage her diabetes, as so many people with type 1 diabetes do. And her control through her adolescent years, through her young adulthood, was not good. And Sophie now has complications of diabetes. She just had an eye operation last week. And I got to know Sophie when she was pregnant. And this was Sophie's blood sugar levels during pregnancy. Now, Sophie was on an insulin pump. And you can see it's very like that graph I was showing before. Each black dot is a blood sugar level. And her sugar levels are just all over the place. Sophie's doing everything humanly possible to get good control of her diabetes, but it's just a nightmare for her. We were notified during pregnancy that Sophie's father, who had type 2 diabetes, actually had been found to have a rare genetic form of diabetes. And so we tested Sophie, and Sophie had that form of genetic diabetes as well. So Sophie never had type 1 diabetes. We'd misdiagnosed Sophie, or she'd been misdiagnosed in the 1990s when she was first diagnosed with diabetes. And Sophie actually always had a genetic form of diabetes. Now, the reality is, for the clinicians who were involved when Sophie was first diagnosed in the 1990s, these rare genetic forms of diabetes had barely been heard about and were not things that were being routinely considered at the time of diagnosis. But Sophie's form of genetic diabetes was such that we could manage her with tablets. And this is Sophie's blood sugar levels on a tablet. And you take it from me that her sugar levels are essentially now normal. She has normal blood sugar levels. So as a consequence of making the correct diagnosis, we've got Sophie on the correct treatment for her diabetes, and we've now given her near perfect sugar control. And this is something that we increasingly recognize is very, very important. 20 or 30 years ago, the options for the treatment of diabetes of any form were pretty limited. It was, if you had type 2 diabetes, there was one or two tablets that we could give, and then bang, you were on insulin. And for type 1 diabetes, you were on insulin from the word go. So it didn't really matter a great deal if we did not get the diagnosis absolutely spot on. But now it really does matter, because the management of type 1 diabetes is completely different now from the management of type 2 diabetes, and is certainly very different from the management of genetic diabetes. So as a diabetes team, we were extraordinarily upset when we made the genetic diagnosis in Sophie. we were happy, delighted, that she was now getting a transformative treatment. But we were upset that we had never thought that she had any other form of diabetes other than type 1 diabetes. And the reality is, if she'd been on tablets from the word go, she would have never developed complications of diabetes. Here's somebody else whose the diagnosis of diabetes was made erroneously. So Theresa May, you can see her there proudly wearing her Freestyle Libre device. Theresa May was diagnosed with type 2 diabetes. She was diagnosed with type 2 diabetes because she's an older woman, and older people get type 2 diabetes. Older people don't get type 1 diabetes. Well, of course, that's nonsense. There is no age limit to when somebody might get type 1 diabetes. So Theresa May endured a year of terrible control of diabetes on tablets until the penny dropped. It was realized that she had type 1 diabetes, and she was put on insulin. I would shudder to think what her sugar control has been like over the last year, though, I have to say. So why do we make things wrong? I'm running over time, but can you give me another 5 minutes? Is that okay? Why do we make the diagnosis, why do we get the diagnosis wrong in people with diabetes? Well, we get the diagnosis wrong because the criteria that we use are imperfect. So age at diagnosis, as I've just shown, is an imperfect criteria. Yes, most people with type 1 diabetes get it when they're young, but you can get it when you're older as well. And similarly, we're seeing type 2 diabetes now develop in kids in their teenage years. There's no reason why somebody who is overweight cannot develop type 1 diabetes. And similarly, there's no reason why someone of South Asian origin cannot get type 1 diabetes. So the criteria that we use are imperfect. Even ketosis, I've always believed that if you've got ketones in your urine or your blood, you've got type 1 diabetes. Actually, that's not true. People, particularly of Afro-Caribbean origin, can get ketones and they've got type 2 diabetes. And we've traditionally not been very good at measuring antibodies in people at the time of diagnosis. So what we decided to do at the Western was measure a hormone called C-Peptide in all our people coming to the clinic with type 1 diabetes. C-Peptide is made at the same time as insulin is made. And so it gives a measure of how much insulin you make yourself. So insulin in a bottle, insulin in a pump, doesn't have C-Peptide in it. And so the theory goes that people with type 1 diabetes will have no C-Peptide at all because they don't make any insulin at all. Whereas people with type 2 diabetes will have very high levels of C-Peptide because they make lots of insulin and it just doesn't work properly. So we've measured now C-Peptide in 757 of the 953 people with type 1 diabetes that come to the Western clinic. And just over 100 of them, just under 14%, have got high levels of C-Peptide, over 200. Now, these are people we believe have got type 1 diabetes. Now, in fact, most of those 103 people actually do have type 1 diabetes. But it's funny type 1 diabetes. And this is one of the things that the C-Peptide program has taught us, is that type 1 diabetes is not a homogeneous condition. There are some people with type 1 diabetes that carry on making insulin for many years after diagnosis. And actually, if you've got type 1 diabetes and carry on making a bit of your own insulin, you generally get better control and fewer complications. We've found that 27 people who we thought had type 1 diabetes actually have got type 2 diabetes. And we've identified 9 people with genetic forms of diabetes, not all of them the same as Sophie's, different forms, but single gene abnormalities. And we've got 12 people actually have come off insulin treatment completely. Now, these numbers don't sound massive, but I can tell you, if you're one of the 12 people that's come off of insulin, that's a life-transforming thing for you. And if you translate these numbers up onto a population scale, then you're looking at substantial numbers of people worldwide. I'm going to tell you 3 very brief stories if Ian doesn't shut me down. Alan got learning difficulties. He was diagnosed with type 1 diabetes at the age of 61 because he presented with ketoacidosis. So it was an easy diagnosis for us to make. Now, for the last 8 years, Alan has had district nurses going in every single day to give him insulin injections. Now, if you think of the cost to the NHS of nurses going in every day to administer insulin, 8 years after diagnosis, we measured his C-Peptide. It was very high. So actually, Alan didn't have type 1 diabetes. Alan's always had type 2 diabetes. And Alan is now on tablets and a weekly injection, and the district nurses go in just once a week. Enormous cost saving. And of course, for Alan, he's now no longer on insulin injections. He's not got any risk of getting low blood sugar levels. This is Jurgita. Jurgita was diagnosed with type 1 diabetes when she was 14. We measured her C-Peptide. It was 670. Her antibodies were negative, and we did a genetic screen, and she was positive for an abnormality in that gene there. On the day I took that photo of Jurgita, I was slightly uncomfortable taking the photograph because it's very difficult as a 50-year-old man asking a 24-year-old young woman in clinic if I can take a photo of her. But I took that photo, and that day I gave her a prescription for this tablet called glycoside, and she stopped taking insulin that day. She's not been on it since. So 10 years after a diagnosis, we've made the right diagnosis, we've got her on the right treatment, she's got amazing control. And here's Callum. Now, Callum's very interesting. Callum is a student at Heriot. He was diagnosed with type 1 diabetes when he was 12. Now, Callum had one very weakly positive antibody, and his other ones were negative. And when I saw Callum in the clinic initially, when I saw that C-Peptide of 800, I was sure, like Jurgita and like Sophie, that he was going to have a genetic form of diabetes. But actually, we screened him for everything, and it was negative. And in fact, Callum has type 1 diabetes. But this is just super weird type 1 diabetes, because Callum, even 6 years after diagnosis, is making stacks of insulin. So we've now managed to get Callum off of insulin. I said to Callum, I don't know what the future will hold for you, Callum. And it may be that you will eventually have to go back onto insulin injections. But he said, well, look, Mark, if I can even get 1 or 2 years off of insulin, I will grab that and take it with both hands. This is very cost effective. The C-Peptide blood test costs £6, and the annual cost of Sophie's glycoside tablets is £6 as well. I didn't make that up. But to the point of the diagnosis, we made the diagnosis of genetic diabetes in Sophie. It had cost the NHS in current terms £35,000. And if we'd not made the diagnosis of genetic diabetes in Sophie, her diabetes treatment over the next 40 years would have cost the NHS £108,000. So Sophie pays for everything in terms of our whole programme of C-Peptide testing. And this is my last slide, and I'm sorry, Ian, for horribly overrunning. This is Sandy. Sandy was diagnosed with type 1 diabetes in 1964. I reckon Sandy's had 45,000 injections of insulin over the last 55 years. So we measured C-Peptide in Sandy. Guess what? It was detectable. And guess what? He's got a genetic form of diabetes. He's got a genetic form of diabetes that is amenable to treatment with tablets. I have to say, it was a very uncomfortable conversation that I had with Sandy. Difficult to explain that. All I could say to him was, in 1964, nobody'd heard of this at all. None of this was known about. But what we need to do is ensure that there are no more Sandys going forward. So one of the things that we're doing is now hoping to roll out the whole C-Peptide testing programme to the rest of Scotland, and I would hope ultimately to the rest of the United Kingdom. So there we are. That's my story. There's Sandy's story. Thank you.